Hello, everyone, and thank you for joining us. It is my pleasure to introduce our guest speaker, Dr. Tania M. Martin-Mercado. Dr. Tania is a clinical researcher with a focus on public health and diversity, equity and inclusion in clinical studies and healthcare. She has deep expertise in designing and executing transformational scientific and technical programs and research studies to determine the safety and efficacy of care regimens, medications, and new interventions for the prevention, diagnosis, and treatment of disease. She is passionate about genomics and its potential to forward precision medicine. Dr. Tania is also a member of the Association for Clinical Research Professionals, ACRP, where she stays up to date on good clinical practices, diversity and ethics in clinical trials, and innovations in clinical research. She has her PhD in biomedical informatics, a master's in public health, and additional degrees focused on health information technology and enterprise technology architecture. In today's Health Bites, our speaker will give a presentation on how implicit bias affects artificial intelligence in healthcare. Thank you for being our guest speaker this morning, and I will turn everything over to you.
Good morning, everyone. Thank you so much for joining. I appreciate it. We are going to go over how implicit bias affects AI in healthcare, and we can move on to the next slide. The agenda for today is to define implicit bias, discuss the impact of bias on decision-making in healthcare settings, discuss strategies to address implicit bias and improve data fairness, and I want to leave ample amount of time for Q&A. These are a few of the learning objectives that we're going to have. The first, identify how to derive risk associated with algorithmic bias. We want to critique and justify opportunities to improve how data is developed, ingested into a system, and used in healthcare decision-making. And we want to execute an action plan to address ethical data concerns and data fairness in primary care and identify systems with better tools for accountability. Next slide. Okay, so we're going to jump right in. What is implicit bias? The definition is a form of bias that occurs automatically and unintentionally, but nevertheless affects judgments, decisions, and behaviors. So I want to focus on the fact that bias in itself is not evil. It stems from a basic survival instinct. It's very human, and it feeds our natural sense to want to belong to a group. There's very little information right now on the reward pathway when it comes to that in-group versus out-group in social situations that can affect very fast implicit bias decision-making. But the point is that when we're talking about implicit bias, particularly when we start to bring in factors like race, ethnicity, religion, you name different variables, I want to remove the stigma that implicit is intentional. Implicit is immediate. There's no forethought to it. It's based on previous storage of interactions, perceptions in a particular situation. So I just want to start with that. Implicit bias is unintentional. Next slide. Where implicit bias becomes an issue is when it shapes the patient-provider interaction. So what I have here in these bullet points are a few real-world medical settings that can impact implicit bias. The first is the specific factors that influence a patient's perception of the care they are being given. And don't read that too fast. So the patient's perception of the care they're being given, not the healthcare professional and their perception of the care they're providing. So just want to make that distinction. Physicians that are high in implicit bias and patients high in mistrust of the medical system make a poor combination and can lead to unintentional discrimination. Implicit bias is not easy to capture or fix, and it's important to acknowledge this in the organizations that we work in and among. Healthcare organizations need to dive deeper into the implications of bias for patient treatment at both an individual and an institutional level. This can't just be fixed with a few meetings and PowerPoint presentations. It may need to be impacted at the policy level for the organizations and institute cultural change in organizations. Leaders in healthcare, IT, and informatics need to be involved in conversations and solutions at the highest levels. Next slide. We're going to look at a few examples of bias in clinical care algorithms. And you're going to see this little nugget here repeated in the next slide as well. Race is a social construct. It is not a biological one, nor is it a reliable measure of genetic differences. However, the use of race as a factor is very commonplace when designing a clinical algorithm. And I mean, it's commonplace today. So here are a few examples from this year. The Black man's cocktail, and this is a real anecdote from a coworker of mine. Is a Black African-American male, and he explained that he goes in to see his physician, and they see that he has diabetes, and he hears the physician toss out, the words to the nurse, prescribe the Black man's cocktail. Nobody in the office blinked. Nobody asked any further questions. They just did it, and it seemed to be a very normal thing for this physician to do. This is before the point of care. They had not even started the encounter. This wasn't entered in the SOAP note. This very limited intake had taken place other than confirmation of the patient and bringing him back to the room to be seen. So zero objectivity. But because he has diabetes, apparently the Black man's cocktail is comprised of other prescriptions for high blood pressure, for more preventive medications, things that they didn't even check to see if he had. So that's one example. The other one that we're going to talk about extensively is race correction. This raises the threshold for use of clinical resources among minority patients. Often, the level of insurance that an individual has directly determines their level of care. And there's also a very high correlation between income and race. We can go to the next slide. And again, there's a largely cited human genome project that took place in 2003, just to reiterate that race is a social construct, not a biological one. This study confirmed that humans are 99.9% identical at the DNA level. So there's no genetic basis for race. Okay, we look at a couple of examples that I have on the slide here. We're going to focus on this kidney failure. So the creatine levels in blood indicate proper kidney functions. Less creatine, better kidney function, lower creatine, more creatine, reduced kidney function. I won't say it's bad, it's just reduced. Black patients' creatine levels are adjusted algorithmically. So this is a mathematical model that exists. So the creatine levels are adjusted under the assumption that Black patients have more muscle mass. And this results in Black patients having a higher rate of end-stage renal disease than white patients. Another example is breast cancer. So when we are looking at the results of genetic analysis, we're looking at genetic variation. This is often confused with race or social determinants of health when these algorithms are designed. So there's no space when you are designing a mathematical model for race because it does not account for genetic variation. It's literally just based on what someone looks like. That's all you can base race on in this context. So let's go to the next slide and I'll go into more detail about why this is important. Jordan Crowley, and this is an example from 2021, so not this year. But Jordan Crowley is who we're going to talk about when it comes to creatine and race. And I wanted to kind of enlarge the picture of him because this is what the physician did when he walked in. He just looked at Jordan. Okay, we can go on to the next slide. So this is, like I said, a very real example of race correction. The EGFR multiplier can make Black patients with kidney disease appear healthier than they are. So a patient's level of kidney disease is judged by an estimation of the EGFR, which normally sits between 90 and 120 in a patient with 2 healthy kidneys. In the United States, patients can't be listed for a kidney transplant until they're deemed sick enough, until their EGFR drops below a threshold of 20. Jordan is biracial. He has one Black grandparent and 3 white ones. So his estimated GFR depends on how you interpret that fact. A white Jordan has a GFR of 17, so that would be low enough to secure him a spot on the organ wait list. But a Black Jordan has a GFR of 21, which means he does not qualify. When they took a look at Jordan, his physicians decided that he was Black, so he doesn't qualify to be on the kidney transplant list. So this is, like I said, a very real example of race correction. We can go to the next slide. I have a few things on the slide here that have to do with complex needs patients. So the algorithms that are used to identify a patient with complex health needs to offer a treatment plan. It sounds very benign, but often the tools that are used to spit out these treatment plans algorithmically have racial bias in them. So I have a few examples on the screen, but what I'm going to read out to you are several that are not on the screen. And I can provide a link to this article. It's from the New England Journal of Medicine. One example is cardiology. And I want to make clear to the audience, these are systems and tools that are in place today. This isn't a long time ago. This is today, right now. So the American Heart Association has a tool that will measure the systolic blood pressure for patients that have acute heart failures. And clinicians have used a risk stratification to guide decisions regarding any type of medical therapy. So if you have the check mark of Black, it adds 3 points to the risk score. Let me rephrase that. It adds 3 points to the risk score if the patient is non-Black. So this increases the estimated probability of death if you are non-Black. So the equity concern in this is that by increasing the use of medical therapy in high-risk patients, you can offer certain interventions earlier. So white patients, or basically any patient that is non-Black, gets a higher risk score so that they can automatically, this is not after the fact, if you hit the little checkbox that says non-Black or just white, really, you automatically get 3 points. So that means that Black patients are automatically deemed as a lower risk using the same clinical resources. So if you hit the box that says Black, you do not get those 3 points, which means you have to appear sicker to get the same level of care as a white patient. So that is one example of cardiology. Another one that hits home personally is the vaginal birth after cesarean risk calculator. It's called a VBAC. And this estimates the probability of successful vaginal birth after a prior C-section. Clinicians use this to decide how to counsel their patient on whether or not to attempt a trial of labor rather than have a repeat cesarean. Okay, so some of the input variables are age, BMI, prior vaginal delivery, recurring indication of a C-section, and the last two are African American race or Hispanic ethnicity. So these are the input variables that go into a VBAC. The African American and Hispanic correction factors subtract the estimated success rate for any person who identifies as Black or Hispanic. That means that the VBAC score presents a lower level of success if the person says they're Black or Hispanic. So the clinician may guide that person away from trying a vaginal delivery after having a C-section. So to put it in plain English, if you have ever had a C-section and then you get pregnant again and you are a minority patient, the physician is likely to steer you towards having a second C-section versus undergo a regular labor and delivery. And that actually happened to me. So I was never offered the opportunity to have a vaginal delivery because my first child was an emergency C-section. And it was the second child, it was never even an option. I was never told I could try for a vaginal delivery. It was automatically scheduled, that C-section. So like I said, these are These are real examples of race correction. And I'll give just one more because I'm just going to stick to oncology because I know I talk about that a lot in other sessions, but breast cancer is one of the most largely studied in research. I'm talking about clinical research. It's largely studied. There's a lot you can now see if you have a biomarker for breast cancer, just largely studied. But when it comes to assessing risk, so the National Cancer Institute has a breast cancer risk assessment tool. Race and ethnicity is one of the first variables, the first input variables when estimating the 5-year and lifetime risk for women without history of breast cancer. So the calculator algorithmically returns a lower risk score for women who are African American, Hispanic or Latina, or Asian American. So while the model is supposed to help conceptualize risk and help people towards screening decisions, it may inappropriately discourage more aggressive screening, more frequent screening among groups of non-white women. So when you're thinking about that, and if you're a female and you're starting to get at the age where you are doing your annual mammograms and whatnot, I would definitely ask questions to see what tool are they using to assess risk. I would just ask that question. So we can go ahead and move on to the next slide. I hope everyone kind of gets the point that these are not old tools that are being used or things that are outdated, or I'm talking in a historical context. These are things that are in use right now today. So what are some strategies to address this bias and increase data fairness? How do we act on this? It's a huge problem to tackle. So one of the best things to do is to bring diverse perspectives in to solve the problem. If you are in an organization and you're in a power to hire diverse data teams. It is very important that data teams represent the populations and the data that is being collected and analyzed. That is, representation matters. You also want to leverage tools to reduce bias. We'll talk about a few of the tools that are available right now today. And the next one is to encourage accountability within your organizations, within your peer groups, within your working groups. Encourage accountability. Consistently demonstrate a commitment to address bias, not just when it's convenient or when someone else is watching. Encourage people to speak up, even if it's anonymous, if the data seems unfair. We can go to the next slide. So when it comes to the benefits of hiring a diverse data team, I outline them here in this slide, and I want to focus on the supporting innovative ideas and advocating for cultural awareness, those two towards the bottom left. Diverse backgrounds leads to new ideas and approaches to problem solving. So I don't mean just diversity in skin color. I mean diversity of thought, diversity of socioeconomic status, diversity of religious beliefs, things that you can't just see all the time, by looking at someone, the things that make those perspectives and points of view deeper and add more rich dialogue, more rich analysis to solve a problem, which stems right into advocating cultural awareness, understanding that patients come in all shapes, sizes, and backgrounds. Awareness of diversity beyond the way someone looks is extremely important. And this is increased when the teams themselves are diverse. And the other options are here as well: pinpointing blind spots, improving team relationships, really understanding the importance of empathy and compassion within a diverse team, adopting practices that say, I want to understand, I don't come from this particular group, help me understand, help me learn. That type of empathy and compassion within groups is extremely important. Next slide. These are a few of the tools that are used by scientists right now, data scientists, to mitigate bias. And this is not an exhaustive list, right? And I'm not going to read all of these to you, but the point is that tools are available, but I'm wondering if you are part of any type of informatics team or any type of data statistical analysis, any type of IT team, or you are on a team that uses IT. It's 2022. I'm sure everyone here has to touch some sort of technology in their day-to-day job. Look inward at your organization and ask yourself, how diverse is that team? And who can properly evaluate an audit if you were going to do an equity audit? Is your team even diverse enough to do one? So these are some of the questions you may want to ask yourselves internally, ask your teams, and most importantly, is the data science team, particularly if you work in a healthcare institution or even a community-based organization, is the data science team diverse enough to personally connect in some capacity with the data that is being collected, with the population that data is being collected from, and the analysis, and is that team truly able to scrutinize for bias? It's almost impossible to do that if it's a homogeneous team. So just something to keep in mind. Next slide. Finally, encouraging accountability. We want to look at dignity over surveillance. This is a time where social media and everyone's got their camera out, and it's almost like it's people salivate at the thought of embarrassing another, or getting someone else in trouble. That is counterproductive. If you can create an environment where people can keep their dignity as you point out a criticism or an area for improvement, without applying any guilt, removing the emotion from the problem, you'll find that most people will want to self-correct. They want to course correct. But if you lead with aggressiveness, or you put your team on the defensive, to say, oh, I'm not racist. That's usually the just very real conversation. That's usually what happens. Oh, I'm not racist, though. Nobody said you were. Calm down. So just have a normal conversation. But you can see, and I'm sure we've all been in teams or in dialogues where there's always someone that you call something out and they get a little defensive. So just making sure that the environments that you're working in allow for that dignity. You don't want people to feel like you're watching them, you're waiting to call out, a racial inequity somewhere. And you want to focus on fairness. You don't want to confuse accountability with everyone thinking and doing the same thing. So I like to use diversity training. Everyone can go through and complete the required diversity training, and organizations can check off the box to say, yes, we took our DEI training this quarter. But what is the action that your organization is driving at to ensure that those trainings have actions behind them, that there is some sort of accountability when maybe something goes amiss, or maybe data is shown to be unbiased, or someone calls out, we're an IT team, we're trying to collect data from a marginalized population, but not one of us is a part of that population. Maybe we should call in a different focus group, or ask more people to join this project. You want to focus on that kind of accountability, not just everyone saying, well, we all took the same training, so we're all equally prepared to tackle this very large problem. We want to move away from groupthink and that type of thing. And that goes into focusing on correction, not blame. So you want to correct bias. You don't want to blame people for having bias. You want to actively correct it. Just pointing fingers and creating a defensive environment really does very little to move the needle. Next slide. So some additional actions that I have on here is to acknowledge the fact that the tools that are used to determine who gets healthcare and the quality of that care can unintentionally increase existing racial bias in medicine. And I think it's extremely important to acknowledge this and unilaterally decide it's a fact. This isn't a discussion. This part is not a discussion. There are tools out there that unintentionally increase racial bias. There's articles written about it, that this is not something that's debatable. What we can do about it is where sometimes the debate comes in. So the first thing is to address the lack of inclusion in artificial intelligence. So this goes back to what I was mentioning before. The lack of inclusion among developers, researchers, individuals, organizations, and entities that fund the development of AI tools. These are some of the areas that need to be addressed and corrected. and incorporate equity in the algorithmic design. So center on health equity, center your algorithmic design. I'm kind of speaking to the developers out there, or even people in project management, program management that are putting together an architecture to create an algorithm centered on health equity and racial justice, because AI can break down structural inequities, but it can also contribute to it if you don't address it in the development process. It's a lot harder to go back and course correct a mathematical design that's currently in use. And what I mean by that is currently, let's use EPIC as an example. EPIC is a huge monolith. It exists. And as we find out more information, as we learn more information about us, humans, DNA, genetics, the ability to then make those changes, make those updates in a system like Epic that doesn't have over-the-air updates like your iPhone does. Updates are something that need to be paid for, scheduled while continuing to practice medicine. So understand that as we're tackling this problem and we're looking at algorithmic design, not all systems are created equal. So one hospital or healthcare system might have a version of Epic that the hospital next door does not have. So how can you incorporate equity in that moment when you have two systems using different versions of an EHR system? It comes into the individual physician saying, wait a second, maybe the tool I'm using to spit out this treatment plan is inaccurate. Maybe it has some bias in there. Or someone on the team, that care team to point it out, because when you can't just go in and create new tools, you have to be able to have the human impact to say, we're still going to try to break down this inequity or this issue that I'm seeing in my tool that I don't have the time to fix, but I can see that I'm using a tool that has bias in it. You have to be in an environment that can call that out. And I know that's easier said than done if there are any healthcare or clinicians in the audience. And then having more diverse and complete data sets. It sounds like I'm making light of this because it seems like that would be easy. But when we're talking about diverse and complete data, it goes back to that example of two hospital systems using different versions of the same EHR. Maybe one hospital is collecting ethnicity data and the other one isn't. That's an inaccurate data set. That is, you can't map, you can't run analytics when your data isn't being collected in a standardized way. Maybe one hospital or EHR system has the option to select sex and gender, whereas the other one only has sex. That's inaccurate. That's not consistent data. So it makes contact tracing, it makes any type of mapping from A to B very difficult from a data collection perspective. So intentionally looking at how medical data is collected and how it's dispersed and how it's shared can assist with removing some of this bias. We can go to the next slide. These are some very team-oriented ways to address ethical data concerns. I'm very big on conducting a pre-mortem, and a little template will follow this slide. But a pre-mortem can identify potential bias before it happens. So if you're on a team, and I encourage you to be open about any misgivings you may have for potential bias for any type of ethical consideration. And this can include how that data is being collected. Not everyone is going to be completely honest with their physician. So maybe having multiple ways to collect that data to encourage trust. Maybe it's not a human interaction, maybe you're using technology or a chatbot to collect data, right? So understand, again, as I said in the earlier slides, that patient-provider perspective. How is the patient viewing that interaction? If there's anything negative, maybe change the way that data is collected, right? The next one is excluding or overrepresenting factors in the data set. So this is, again, work for my developers, my people in technology that are building these algorithms. Make sure there are social, cultural, and economic factors reflected in a healthcare data set. That is extremely important because any bias can create unintended unfairness and ethical concerns. So that the data team itself needs to ask, will they leave groups of the population worse as a result of algorithmic design? Or what are the consequences if the algorithm is used improperly or diagnosing improperly? The last one is designing questions for bias impact. So there are templates available, and we can go to the next slide and I'll show one of them. There are templates available, and this is just one. This is on brookings.edu. I put the website on the left side there. And I love this template because it's actually asking some very real questions. Who is the algorithm for? But also who's going to be affected by it. I think we've seen it sometimes that isn't always the same. Do we have the ability to train that data? How is bias going to be detected? Who's going to measure it? And how are we going to ensure that it's measured equally across protected groups? So I won't go into too much of this template, but I love this template. If you have an IT team that can digitize this template and something you can do at the beginning of a project, even if you're looking at doing kind of an intrapreneur project in your healthcare organization or community-based or whatever organization you might be working in that has a patient impact, you can use this before you start putting hands on keyboards to say, how are we going to do this? Who's going to be impacted? Have we included diversity? Have we considered all populations and who would be affected? Have we thought of different cultural, religious, sexual orientation, socioeconomic status? Are we bringing all of these in to give the algorithm a proper purpose and have sufficiently diverse data? So brookings.edu, great template. Okay, next slide. I think we're ready for Q&A. Yes, okay. So I'm going to turn my camera back on because I don't want to talk at people, but I would love to hear from the audience. I'd love to hear what questions or comments, concerns, thoughts anyone has.
Okay, well, thank you for that wonderful presentation. So as people are busy kind of typing their questions into the chat box, I wanted to start with a question for you. So with our audience, we have a lot of health science and medical librarians. So they're not working directly with the AI tools, but they're working with the students who will be working with those in the future. Do you have any suggestions for trainings or what we can do to help with this issue?
Stop changing standardized data sets. So at the federal level, if we can just agree on a standardized data set for healthcare, what questions are going to be asked to collect race, ethnicity, zip code, and all the demographic data and stick to that, then you create an opportunity for different organizations to have innovative tools put in place based on a foundation that has the same taxonomy. You're not changing, okay, well, this hospital or healthcare system can use it this way. So students and anyone that is looking to jump into, this space or is working to jump into this space, again, it's keeping in mind what has your experience been when you go into a hospital? How do you feel giving off the data? And understand maybe if you're working in groups or you're working in a team for school, how are you able to properly impact the population or populations without any negative bias, without any unintentional consequences? And while I'm saying this, I'm thinking of a very specific example of, remember when COVID vaccines were being distributed in marginalized communities specifically, so certain supply and demand, analysis was taken. These communities are marginalized. They need a higher dosage, a higher quantity of vaccines in this zip code. But then people would come from outside of that zip code and hop in front of the line, right? So that is an example of what could have been done differently there, what could have been designed. You might not have to be developing the tool, but how do you develop the program so those types of things are prevented? That was an unintentional consequence, but it happened. And so how do you correct that? So when I'm talking to students, I try to get them to think of a real problem that just happened in their community. You just got to pick one and approach it from there, even if you're not coding, even if you're not directly impacting any type of mathematical model. we're all patients. And let me know if that answered the question.
Yes, thank you. And now, especially with the COVID, I remember, senior citizens had to go online and like quickly scramble for appointments. And so, yes, I had to help family members that were not quick at typing to secure their appointments. So thank you. Okay, and we have another question. How does bias in healthcare contribute to health or to patient outcomes? And can this be viewed as a form of malpractice?
Oh, so I am not a medical doctor, right? So I'm going to stay all the way away from that malpractice question. But it's going to be hard for me to answer that question without making it seem like there was intent, because I want to be as real as possible. There are a lot of assumptions that come into place when it comes to training AI. And it's important to remember that humans train artificial intelligence. So if you have a human being that automatically has an assumption that they believe is correct, I'll use one that everyone should know when we live in America. Black people are more athletically inclined than white people. So if you see someone that's Black, the likelihood of them being an athlete is very high. You take that kind of mindset and put it in healthcare. Black people have a higher risk for sickle cell anemia than white people. But if you look at someone, can you really tell if they're Black? So that type of bias, if you're just inputting data based on what you see and you don't ask questions, you don't ask, just because someone walks in and they look like what you think the last person that was in that demographic looks like, and you code them that way, you are essentially changing their health record. You're changing their course of care. So it's important to understand that. And based on just the few examples I just submitted, when it comes to some of the tools used for certain clinical treatment, right? If you're Black, you get this level of treatment. If you're not, you get that level of treatment. So how you code people is right now affects the care they're being given. How to correct that is to have a dialogue with your patient, to have a dialogue with your staff if you're in a healthcare organization, or if you are just putting out information, right? So when we're talking about teaching, what is being taught in schools when it comes to clinical treatment? Are you being taught bias, even if it's unintentional? And could you call it out to your professor or whoever's leading that class, in a way that says, maybe we're doing this wrong. So let me know if that answered the question, because it's very hard. It's also very expensive. I'm not going to pretend like it's not to go back and change technology. Technology is actually easy. The cost in changing it while you are practicing medicine is what gets costly. And then looking at how physicians can just stop for a moment and ask questions instead of working solely off the tool. Let me know if that answered the question. Okay, it did. Great.
Okay, yeah, the questions are starting to come in a little bit faster, so let's see how many we can get through. The next is, how do you know when racial algorithms are included in calculators? If race ethnicity is asked, does that mean that there's a risk that the math is in there to make racial adjustments? And sites such as UpToDate, they have a lot of calculators. So how do you know?
Assume that it is, because it is, and you can tell. And I get where that question is coming from, because we have all been in intake, right? We've all filled out the form before we get seen by the healthcare provider. Race and ethnicity, and oftentimes it's just race, is on there. There's a reason for it. I don't know what the reason is, because it depends on how that data is being collected. But if we want to talk about social determinants of health, which falls under public health, that's not clinical treatment. You want to collect that information to know, are you in a zip code that has proper access to a pharmacy within a reasonable distance if you need to be prescribed life-changing medication? Do you have access to get to a base where you live? That's one good reason to understand that certain geographic locations don't have that access. But if you're using race to provide a course of treatment and you're being asked that on the intake form, I would ask your provider. I might have people in my family, I was wondering why I wasn't getting prescribed They wouldn't increase my pain medication. I was like, what did you mark on the form? So, you sometimes you do need to be proactive and ask your physician, but that race is being collected for a reason. And it's not always a bad reason. Sometimes you want to know, do you have proper access? Do you have equitable care? Are you being treated fairly? Where it should not be used is in the case of clinical treatment. So just because I'm Black doesn't mean that my muscle mass is bigger. So don't prescribe me medication based on that adjustment to me internally, based on what you think I look like or what you think I am, based on what you see, right? So that's where it becomes a little squirrely. Let me know if that answers your question, because it's a delicate line. There's a place for race, but it's not in clinical treatment. So let me know if that answered your question.
Okay, and then based on something you just said, I'm going to skip over to this other question first, and then we'll come back to the others. Do you have any suggestions for health consumers and what they can do about this problem?
Ask questions. And so I know this is difficult. We are all, like I said, we're all patients. And I have found myself being in the doctor's office and they're just asking their question. The nurse practitioner or whomever is doing my intake. And I find myself wanting to, I don't want to tell you, I don't trust you. And I'm in research. I don't want people to have that reaction to me. And yet I still find myself pulling back like, because I'm overthinking, how are you going to use this information? What are you thinking? What are you actually writing that I can't see in my chart that's going to affect my course of care? So even I have these little points. And so I have to even force myself to say, why do you want to know that? What is that particular variable going to be used for in my care specifically? But I didn't know to ask that question when I was younger. I didn't know this was a thing. I just thought I got the same kind of care everyone else did. I didn't realize until I started doing clinical research that it's not all created equal. So it is up to us as patients to be accountable for the care that we're being given and asking questions, because the physician might not be able to take a beat and say, I don't know. This is just ask this. It's a tool. Like the physician didn't create the tool. Like they didn't go back in their office and create it. So you want to be able to ask questions. And I understand that that's sometimes difficult when there's already a mistrust of the healthcare system, or your healthcare is just very personal. So asking questions like, why do you need to know that? When you're kind of putting your care in the hands of someone else, your provider, can be difficult, but I'm encouraging, if you have that concern, ask how your information that you just provided is going to be used in the course of care you're being given. Can I answer the question?
Okay. I think so. If you have follow-up, you can type that in the chat. We've got a lot of questions coming in. We have one that seems fairly popular. I'm starting to learn about common data elements to standardize data collection. CDEs seem to have a lot of potential to reduce biased data collection. Do you have any thoughts or more detail about CDEs?
So I'm going to take a step back, and when I was talking about having standardized data sets, so think about the CDC, think about the FDA, these organizations that are trying to collect a lot of data in a short period of time in the midst of change. So, and I don't want to confuse standardizing data with things like HL7, FHIR, where it comes to data transmission. I'm talking about collection. So name, last name, first name, and even certain things like how many surnames can you have? That's a standardized intake, right? That's even not consistent between them. So I like to see, if you're taking data at the federal level and you want to drill down and to do proper analysis, you want to do proper mapping, accept the fact that you're probably going to get dirty data. That data needs to be clean, and you may need to look at those data sets as you're ingesting it to say, okay, these are not the same. Just the intake themselves are not the same. It's not one is better than the other. They all seem to come, you're going to start at the federal level and go down. For the reason I say that is for like your payer information, insurance companies, healthcare insurance companies, they get that data, population, zip code, and they need to combine that with clinical data. that's not always going to be consistent. So it's not one organization creating this data standard. You have to understand that every organization is all over the place. When population health and public health doesn't collect the same data as clinical informatics, right? But they need to talk, they were required by law to talk to each other. Those data sets are not standardized. So when it comes to mapping, how can you do things like contact tracing, right? So when you're thinking about one organization or one entity and the data standards that are, first of all, are they trying to put out data standards and determine if that's actually what they're doing, if they're trying to standardize data transmission, how you and I might exchange data needs to be identical for security purposes. But I personally don't focus on any individual entity because they're all doing it different, and where they are originating that data from matters. So looking at those data sets, where is the original data coming from? Are they the same? Becomes important. And it's okay to throw out bad data and start over. It's time consuming, but make that decision as well. Let me know if that answered the question, because that was seemed like a small one, but I probably overcomplicated it.
Thank you. We have another question. What are clear actions we can take as information professionals who work with students and faculty with instruction and research to better drive diversity and more fair opportunities? How do we become better allies to our peers and communities beyond just stating that we care about DEI?
Oh, that is a great question. First, I would say if you come from a majority population, right? So if you're part of a majority, know when your voice is not needed in a conversation. Know when it's just time to listen. Not everybody needs to be saved, so to speak. So there's a lot of talk of allyship. There's a lot of talk of, how can people that really want to see improved outcomes, they really want to see improved equity, what are some actions that they can take right now to do that? And sometimes it's listening. Sometimes it's just being still and listening, because what you think the problem might be, you might think the problem is access to a pharmacy. So you insert a solution of more transportation, when really that patient isn't coming to your provider because they don't feel comfortable with the provider. It had nothing to do with transportation. So that's an example of allowing people to honestly speak about their experiences, particularly, or what they think the population wants to see. That template that I showed, where it's very briefly, it's almost like an interview that you're doing amongst your team to say that feedback loop. What is the feedback loop? Are we developing tools and technology for a population that we actually have no knowledge of? And if someone is able to say, yes, I am developing a tool for the LGBTQ community, but I'm on a team with all cisgender males. Maybe you need to insert and ask people to participate and then let them participate. Don't insert your assumptions into that experience, into that audit. So it, to me, starts in a classroom, allowing that dialogue to take place in a classroom environment so that you can start to do that in practice in your careers as you get started. Let me know if that helps answer the question.
And also, speaking of the template, I know we've had at least one request. If you happen to have the link for that template.
Okay, I know it's on brookings.edu.
Yeah. Okay, if you can find it to us later, we can send it out. Okay. Along with our recording.
It's literally on the web page, and you have to copy it's not like an attachment on the web page.
Oh, okay.
It's literally embedded in the page. So let me know if that helps. Okay. But I will get it to you. That way I can get you to the page itself that has the template on it.
Yes, we can send that out when we send out the instructions. Okay, let me go back through. So other than standardized data collection, are there other government policies that can help create more equitable health algorithms?
Oh, the government, they try so hard. What are we now at the quintuple aim? Have we for equity? I think if it is allowed, because a lot of these things, you can have the best equity, you can have the best intentions, but it comes down to policy, right? And how policy is put into place. That's where the government comes in. It's not going to be necessarily at the technical level how we create, because there should not, and I don't see this happening because it's too subjective. how do you evaluate whether someone's team is diverse enough? That should change based on the problem that's being solved, right? Maybe diversity in teams needs to be conducive to the problem being solved. One problem may not have the same diverse makeup or need the same diverse makeup as another problem. The government really shouldn't get involved in that because they're kind of into policy, right? That the government is there to provide public policy, population health policy. So when we start, I don't like combining politics and healthcare. I think we've seen that that's a really trash way to go. So the government collects data to ensure equitable access to care, and it should be very benign like that, so just data in without any action behind it. That's when the need for community-based organizations, for state health, local human health, health and human services organizations to take that data and do something with it. Innovators, startups, healthcare startups, digital health startups to do something with that data. But if there could just be a standardized data collection, and I haven't seen this happen because this has been asked for long before I started doing clinical research. Can we start collecting data in a standardized format? It hasn't been done yet at the federal level. So I am not seeing a way for government policy to impact proper healthcare data collection, and I'm not sure those lines should cross all the time. I think there should, this is just my opinion, by the way, I think there should be some way to standardize transmission, and we have some of those standards in place, and some way to standardize demographic data so that it's the same. But where we should not start standardizing is when it comes to ingesting maybe genomic data, or when it, the government should stay away from purely clinical, purely healthcare related data like that. That's just my opinion.
Okay, thank you. I think we have time for one more question. And I think this is one that hasn't already been answered in the chat and kind of draws on your clinical trials background. A lot of basic research is done in male animals because of the hormone swings caused by the estrus cycle in females. A consequence is that a lot of drugs are not adequately tested in women before approval. And do you have any suggestions on how this could be corrected? Because a lot of the human clinical trials have restrictions on testing in women of childbearing age.
Yes, yes, that is absolutely true, and it does cause a problem. I think, wasn't it just recently they put out the information that women suffering from heart attacks need to have a different course of treatment than men, and that was this year, last year, like really recent. So when it comes to clinical trial recruitment, there needs to be proper informed consent. And yes, there are certain trials that prevent the use of women of childbearing age, but it's usually for a really specific reason. Either the drug has been shown in the animal phase to have negative consequences for the female sex. Staying away from that, though, when you are designing the patient recruitment arm of your trial and you are creating that informed consent, do the best you can to have that recruitment be as diverse as possible. And you may need to avoid this is tough because we're talking about the funds committed to a trial. You need to move, but patient recruitment is the most expensive part of the trial. You want to make sure the patient stays in for the duration of the trial. And this is, again, representation matters. The makeup of that trial matters. And if you don't have a good diverse makeup of male, female, multiple ethnicities, you can't start saying that the drug is like precision medicine because you didn't test it across a diverse population to say that. Like, there's certain things when it comes to patient recruitment. If you can't get a diverse population, you need to, and this is at the PI level, with whomever the sponsor is, really make the determination, why are you putting out a drug that you have not properly tested across a diverse population? Is it just to push the drug out? And is that the right thing to do? And then going back to that template, who is going to be affected by that choice? So if you can't get the proper patient recruitment, take a step back And like I said, I know it's easier said than done because funding is important, and how you get those funds, how those funds are allocated. There's a lot of pressure to just get it done. This is going to be you and your conscience to say, okay, we can push forward because we do have males that want to do this, even though this drug might be prescribed mostly to females. You know that going in. So adjust your patient recruitment and maybe take a step back until you get the patient population that will represent the drug that's being used and why that drug is being prescribed, or that course of care is being prescribed. Make sure it matches the population it's intended for. Again, really strong personal opinion there. So,
well, Dr. Tania, thank you again for this wonderful presentation and your answers to all of our questions today. It was a pleasure to have you with us.
Thanks for watching. This video was produced by the network of the National Library of Medicine. Select the circular channel icon to subscribe to our channel, or select a video thumbnail to watch another video from the channel.